Morning, everyone. I think only speakers are available in our course. Sunday morning. We have just completed last year 75 years of IOL journey. It's a change life of millions, if not billions, over the past 25 years. I will in this course we'll discuss the history so far we have reached and some new cutting edge technologies will be available in next coming future. So thank you. Over to you, Dr. Mahanto, for talking about future 75 years your IL journey. No one. এটা height.
But everything is getting recorded. So thank you, Arup, and I'll be talking on design of fast IOL and changes till foldable IOLs. I have no financial interest to disclose. So this was the generation 1 IOL that lasted from 1949 to 1954. This was the original Ridley posterior chamber lens. So everyone knows Sir Harold Ridley performed the first IOL implantation on November 29, 1949. This groundbreaking procedure revolutionized the field of ophthalmology. His method was executed in 2 stages. First, he performed the ECCE, and then 3 months later, he proceeded with the IOL implantation. This strategy was designed to maintain stability in the ocular milieu following the ECCE to avoid any negative outcomes. This is a photograph that was extracted from an original film and subsequent videotape of Ridley's 8th IOL implantation performed at St. Thomas's Hospital in May 8, 1951. This is a gross photograph taken from the Miyake view post-mortem, shows an eye with a properly centered Ridley IOL. This patient had bilateral implants and enjoyed excellent vision for 20 years prior to her death. Then this company, Rayner, was born, and the part share was held by Sir Harold Ridley. The problem with IOL power calculation in Ridley's lenses arose because they didn't consider the variation in refractive index between the proteins of human lens and the plastic of the IOL. Consequently, original lens ended up being excessively thick, and the first patient's refraction revealed high myopic overcorrection of over 14 diopters. Ridley was ostracized for a time from the mainstream of ophthalmic surgery and was forced to abandon his original posterior chamber lens due to complications. It is dangerous to be right in matters on which the established authorities are wrong, by French philosopher Voltaire. Then Ridley's contribution was recognized from the year 1976 to 92 by the American Academy of Ophthalmology and Otolaryngology in San Francisco, then by the European Implant Lens Council in Jerusalem. Then the Royal Society of London gave him knighthood, and then subsequently got the Gallstrand and the Gonin medals. Then came the generation 2 early anterior chamber lenses. In 1950s, a new breed of IOLs are born, which are more stable as it was supported at the angle. Technically, it was very easy to do the surgery, and it could be implanted even after ICCE. Baron implanted the first AC IOL in May 13, 1952. It had a shape of a thick convex disc bent towards the endothelium, leading to glaucoma and corneal decompensation. As you can see over here, it was a thick lens which was almost touching the endothelium. If you compare it to the modern day anterior chamber intraocular lens, you will see that there is a huge difference in the thickness of these two lenses. Then Stampelli began implanting the tripod lens in 1953. It became the prototype of rigid IOLs. The problem was correct sizing because the size of the eyes were different, the angle to angle measurement was different, so the sizing was a huge issue. Then Peter Choice came up with this particular IOL in 1956 and it modified up to 1 to 9, Choice Mark 1 to Choice Mark 9 in the next 13 years. On the right, you will see a picture of Choice IOL implanted in a patient's eye. The problems were again corneal decompensation, bad manufacturing techniques, residues on the lenses from sterilization process, and fundamental design flaws leading to serious inflammatory reactions and erosion of the fixation elements in the UVL structures. Then came the iris supported lenses. Those are the generation 3 lenses. So this was a collar stud lens developed by Epstein, and you can see it's a collar stud lens on the left hand side top. And then came the Maltese cross lens and the Copeland lens. This is a Maltese cross lens on the bottom. And this generation lasted from 53 to 75. Then Binkhorst developed these iris clip lenses 4 loop in 1957. And then he developed iridocapsular fixation in 2 loop in 1965. So these are the 2 lenses, on one on top, the 4 loop, and on the below it's a 2 loop lens. Again, it pronounced iris pigment epithelial defects and atrophy occurred. Pigment dispersion glaucoma occurred, corneal complications occurred, so again these became obsolete. Then Binkhorst developed this first iris clip lens, 4 haptics, 2 fixated in front of the iris and then 2 behind. Binkhorst again developed 2 loop iris clip lens for iridocapsular fixation. Fedorov modified this design to Fedorov 1 and 2 and named it Sputnik due to its appearance, 3 haptics in front and 3 behind the iris. Then Wurst came up with this particular lens. It's called the medallion lens, developed by Jan Wurst, included 2 fixation holes, and through these fixation holes sutures were passed and these were sutured into the iris. But however, biodegradation of nylon sutures caused lens dislocation. In 1970s, Wurst develops the iris claw lens. It's called a lobster claw lens. You can see over here there are small gaps which you separate and tuck it with the iris. On the right, you can see a Wurst lens in place. Then Singh modified this into Singh Wurst iris claw lens, which we have all seen. Then came the generation 4 intermediate anterior chamber lenses. So these were ACIOLs with flexible or semi-flexible haptics, Sarjidev style Lieski lens, Silco Optiflex ACIOL, IOLab Azar 91Z lenses. So all these had open or closed loops. These again caused corneal decompensation, pronounced uveitic reactions, erosion of the anterior chamber angle, ciliary body area, cheese cutter effect by closed haptics, taken off the US market in 1987 by the FDA. Then came the generation 4B lenses by Kielman. This was the lens with 3-point fixation, also called the pregnant lens. And on the right is called the normal ACIOL, which we see today is a Kielman multiflex ACIOL. Then came the generation 5 lenses with improved posterior chamber lenses. This was the first PMMA PCIOL by Pierce. It is a tripod PCIOL developed in 1975. Then came the shearing J haptic PCIOL in 1977. Then Anis PCIOL with closed circular haptics in 1977. In the 1977 PCIOL with open J haptics introduced by shearing represents the prototype design for the PCIOLs that we see today. The looped haptics were first made using flexible materials such as polypropylene. During the following years, many variations to the haptics were made, and it turned out to be a single piece PMMA lens. The haptic designs were modified J haptics, C haptics, and modified C haptics. And then come the generation 6 lens, which I am not going to speak about. This is a modern capsular posterior chamber lenses and modern anterior chamber lenses. If I have seen further, it's by standing on the shoulders of giants, Isaac Newton. So what we are seeing today is we are standing on a shoulder of a giant, and seeing it further. Thank you very much, and special thanks to Dr. Padmavati Bhattacharya and Dr. Dipanjan Pal for the research. Thank you so much.
Thank you, and it's a wonderful talk regarding the history of the IOL. So, we are actually standing on the shoulder of this giant. And today we want to say something, Siddhartha.
The initial Ridley lenses were PC lenses or AC lenses?
PC lenses.
This is a PC lenses.
So he did
ICC came later. ICC came much later than the ECC.
Okay. So these were initially they were all PC lenses, and
Exactly.
then it became AC.
Became AC lenses.
Then they started doing ICC and putting AC. And
See, everyone forgot who invented the IOL until David Appel started researching this thing and reinvented that Harold Ridley's actually invented.
Right.
So,
This is really interesting.
actually, he was a dumped. He was a dumped. So this is a very pathetic history. If you go through this history of IOL, so far we have reached. There is a cutting edge technology. Today I'll talk about the EMV and EDOF IOL. I have no financial interest. So can I have the slide? Yeah. Basics of no financial interest. So this is we came a long way actually. This is the invention of the bifocal IOL started in the concept in the 1984. When in the pseudophakic eye, myopic eye, there is a decentration of IOL, and the patient used to see that the aphakic eye for the distance and the pseudophakic eye and the distance, and the first lens came is the fusion of the two optics to 18 diopter and 21 diopter and 24 diopter. But that's a refractive IOL. Then came the refractive design of resume and array, and then diffractive, and coming again we are towards refractive one. So if you correcting the presbyopia correction, if it's a trifocal, give you full correction as we said, and if we consider EDOF, it will correct the partial correction. So the concept is what EMB, extended depth of focus, or enhanced monovision. What are they? So extended depth of field intraocular EDOF is a consider the lens as a definition. It will give at least 0.75 advantage in the near. So then it is called EDOF, and it is create elongated focus rather than a multiple foci. So this concept, though the enhanced monovision is there is no definition is available in the literature. What is enhanced monovision? But there is a definitely definition of extended depth of focus. So far we have a two diffractive lens we consider as a EDOF, that is a Symphony and Attilara. But over the year, there is a concept, the change. Now there is amalgamation of the what is EDOF or EMB. There is a lot of lens which is available in the market, starting from small aperture IOL to Minuel, that is by Minuel Proxa by Sifi, Eyehance by Johnson & Johnson, VVT by Alcon, PRC by again Johnson & Johnson, Vivinex Impress by Hoya, Minuel Proxa by Sifi, Ray1, Isopure by VVI, and AdTech Comfort by AdTech in the Indian market. These are all the lens. So what is aspherical and spherical lens is? The spherical lens and aspheric lens, there is a difference. Spherical lens create a elongated for the loss of light. That's why this came. If you see the optics of the spherical and aspherical lens, See, if it is spherical lens, from the center to periphery, the spherical lens 20 diopter. So, if it is the angle of light is a different, then it give a defocus. But what is in aspheric lens? It is if it is a 20 diopter lens and the periphery it is actually 19.1. So it give a sharp focus. So this is the spherical aberration which is give a some elongated focus. The most of the company actually EDOF or EMB actually playing in this game. So what is now? It is a perfect rate and a channel focus rate. These diffractive loss of light, they actually play to utilize this loss of light for the EDOF technology. So what is the ideal EDOF? Ideal EDOF should be that the light would be the channel, the small channel, so that there will be less halo or diffraction. So why it is came? I am just showing two picture. If it is a diffractive lens, you can see that this is one foci here and another foci here. But the light from the first foci passes through, and the second foci, these light causes halos here. So this is the main problem to make a channelized focus in the EDOF technology. So now this is whatever the EDOF waveform shaping, what is the spherical aberration or refractive design, J started to make a channelized one so that there is a loss of light less and create a loss of less halo. This technology actually concepted from the aperture lens. This came first. EDOF lens is actually the aperture one, small aperture lens. But there is a loss of field, that's why it's not popular. So, but the concept came from the aperture lens to now the wavefront shaping lens. I am talking about the central active zone. So, they make the central active zone is very small, and it is they are playing game how to make a small region of the central zone, active zone, so that it able to focus, it creates the elongated focus and rather created less loss of light or created less halo. But these are they are making, and these are the actually their mode of action, how they play the optics of the lens. So came to the first eye hands. Eye hands is a beauty, it's a very small spectral zone. That's why sometimes it will not, patient will not see the effect, and doctors will not appreciate the effect, because they have created the sharpness, curvature of the lens, and it has a very small central zone. As it is a very small central zone, there is a less number of halo and the glare in this lens. I am not going to detail. So it is called as a EMB, enhanced monovision. It is intermediate, gives the advantage of most of the time 0.5, not point more than that, and very good in the distance vision. So came to the evolus of the CF lens, and it is actually played in the spherical aberration followed by negative aberration into the anterior surface. The zone is almost 2.5 millimeter in the central zone, and 4 active refractive zone is with spherical aberration opposite side is distribution in the central zone. So this is give you the very good intermediate distance, but not as good as a distance like eye hands. But it is definitely for intermediate action, it is definitely give you +1 advantage, and it is for the intermediate or EMB. If you consider EMB, it works better than eye hands. Now came to the mini OL technology. This is a EDOF lenses. This is made of hydrophilic lenses, and this is the technology. It has a central positive aberration, spherical aberration, followed by the negative one, and then the power. This is very good EDOF lenses. Central, he has a three zone D1 2 millimeter, D2 is a 1 millimeter, D3 is a 3 millimeter. These are alternate spherical aberration created the elongated focus into the channel. You can see the channel is this. There is a loss of less halo, less loss of light, but it is able to give you very good focus in the intermediate distance. So if you consider, it's always, most of the time it's always in between +1 to 1.25 advantage for the near. CV is very good, and it is a intermediate vision, almost N6 at the 60 centimeter, and distance vision. Again, if you play with the central part of the any optics, it will give some kind of disturbance, inferior quality in the distance vision compared to the aspheric lens. So it is a good distance vision, but not as good as distance vision like IHANS or Evolux. Now came to the Rayner one. This is a very interesting, this is a non-diffractive design, blended edge with the reduced longitudinal spherical aberration. This is the same concept used by the CFI, but it is a blended properly, and this is a design by the Graham Barrett. So it is a give a channelized elongated focus, which is give you 1.5. Then this is the beauty of the lens. This is the central part is a very small, so it is a very less halo, almost no halo. So it gives a advantage is almost less than the, I call it less than the CFI's mini OL, but it is a give advantage of 0.7 most of the time. It is for the EDOF, EMB, it is considered EMB, but it is give a better intended vision compared to IHANS. Now came to the wavefront shaping, Z wave. This is stretching and shifting. So looking, this is a VVT. I go not going to the detail of the technology, but this is a 2.2 millimeter zone in the central zone. So if you consider this, it's a very good EDOF lenses. But if you consider it's a aspheric design to Clarion, it is inferior for the distance vision and creates some kind of halo many patients. So if you consider advantage, I am going VVT, it is most of the time it is +1 advantage, and many times it's give you +1.5. That means patient may need 0.75 to 1.25 for the near vision. Viviness Imprex also is it's slightly different technology. Again, it is create elongated focus. Is the central 2 millimeter has a smooth combination or even order standard aspheric surface, and the peripheral part is standard aspheric surface, but central part is the spherical aberration creates some elongated focus in the central part. Its optics looks like this, and again, as I said, that these have a give, it's a very good distance vision, Vivinex Impress, and it give advantage of 0.75 of the near. So Vivinex Impress is considered as good as distance vision like IHANS. Now this is a new lens in the PRC. This is they called is a refractive. Central zone is 1.2 millimeter. So and it is considered as a EDOF, and technology, it is a refractive surface in the posterior surface and aspheric design in the front surface. So it is a very good lens, and most of the time is a give advantage within 1 to 1.75. It's a very good for the EDOF, considered to EDOF. So Isopure, this is another lens from the BV high, which considers a very good very good distance vision and advantage of 0.5, 0.75, intermediate 70 degree, it is 67 to 68 degree, I call it 70. 70, it's almost, most of the time it's a give a N8 to N10. So I am discussing all the, now it is, I think I crossed the my time. So I'll not go detail once again this. I just end up my top with one Indian lens. This is a very good for intermediate vision and is a AdTech Comfort by AdTech company. This central zone, it is a pure refractive one. Very small central zone, it is addition is at plus 2.5 in the central zone, 1 millimeter, and central 1 millimeter, but they blended the optics so nicely, it do not have any kind of halos and glare in the distance, but most of the time it is a give advantage of +1 in near vision. So thank you so much. I'll hand over my topic, Dr. Siddhartha Ghosh. No, you will, yes, Anurag. Anurag, you will talk about the Ovijit's topic also? No. Okay, we can discuss Ovijit's topic, yes.
Thank you so much, Arubda, for the kind invite and kind inclusion into this wonderful instruction course. Good morning, ladies and gentlemen. So the concept of diffractive IOLs actually originated from, if we strictly look at the history, it originated in the 18th century. In the 18th century, we had a lot of waterway transport. I mean, a lot of ships used to travel in the seas. And to show them light and to show them the existence of land, we used to have lighthouses. So how the lighthouses used to function was, there was a source of light and there were huge convex lenses all around it. The rays used to diverge from the light source and the convex lenses used to parallelize them and throw them many hundred kilometers away. That's how the lighthouses used to function. Until a gentleman called Augustin Jean Fresnel in the 18th century came up with a new concept. He said, why should we have such thick lenses? We can have a thin lens and mount one lens over the top of another. That's the concept of Fresnel prisms. So there are multiple lenses which produce the same effect. This is how the effect is produced. So multiple lenses stacked over one after the other. They also converge the divergent rays, make them parallel, and throw them onto the distance. So this is the basis of diffraction, how diffraction happens. And to understand diffraction properly, we have to go to Thomas Young's double slit experiment. When the light passes through one slit, diffraction is the course change that the light incurs when it comes across an obstruction. So this is where the obstruction is happening here, and the light starts diffracting from there. Now, if you have another two other slits in front of this light which is diffracted from the first slit, they get divided further. All right. This led to the concept that light rays actually do not travel in straight lines. The moment they hit an obstruction, they start traveling in ripples or waves. Beyond the second paired slits, what you have is many light waves. Now, these light waves will obviously interact with one another. And we know that all the waves have a peak and a trough. When the peaks of two waves collide with one another, they form a constructive interference. But if the crest of one wave collides with the peak of another wave, then it produces a destructive interference. That's the reason why on the screen you have different dark zones and different light zones. The most brightest light zone is known as the zero order focus. That's where majority of the waves meet. and then progressively the first and the second order foci are built. Interspersed with them, there are the dark zones, which are obviously the result of destructive interference. So if you extrapolate that onto the IOL optics, the zero order is actually the distance focus, where maximum light is focused, the first order for intermediate, and the second order for near. So that's what the Thomas Young's double slit experiment showed us. And if you have a screen which projects the light, this is how it will come as onto the screen. To understand this interference a little better, if you look at this picture, herein the crest of one wave is not actually in sync with the crest or the peak of another wave. So the light wave that has a height is shallow or dwarf. As the waves come close, the height increases, and it's at its highest when the two waves merge together. So that is how the effect of constructive interference is built on the focal point. Now onto the diffractive IOL, the steps actually work as slits. The steps that we have work as slits. When light passes through the slits, it obviously forms a wave. Two lights passing from two adjacent slits here should have complementary design or complementary architecture for the peak of one wave to clash with the peak of another wave. And for that to happen, the two waves have to be spaced one wavelength apart, or two wavelengths apart, or three wavelengths apart. In other words, an integer of 1. If they're spaced 1.5 wavelengths apart, then the crest of one wave will collide with the peak of the other wave. Okay, so they have to be integers of 1. That is how a bright focus is produced on the focus side. Now, since the steps of the diffractive IOLs cannot be made opaque, it is imperative that some amount of refraction also would take place, which actually leads to the photic phenomena that all the trifocals are associated with, in association with the destructive interference as well. Now, there are certain factors governing this diffraction. One is the color of light. The red light diffracts the most, while the blue spectrum of the light refracts the least. Okay, that's one factor governing it. And then the other is the slit aperture. Narrower the slit, more is the diffraction. Wider the slit, less is the refraction. So it's less when the slit size progressively widens up. Now we come to the IOLs proper, with this knowledge in the background. What are the components of interest in a trifocal IOL? One is the central bullseye. The central bullseye is the base power of the refractive lens, and it's dedicated to either distance or intermediate. We'll talk about it a little more. And the diameter of the central bullseye actually determines the focus. For example, there's a mathematical calculation which determines how much the central bullseye can be for a particular ad power. Like for example, the Restore Plus 4, which came long back, the diameter of the central bullseye should be around 0.742. Similarly, if the ad power is 3.25, which is the ad power of Panoptix, the central bullseye should be 0.823. Now there's a problem with that. If the central bullseye is less, you cannot implant it if the angle alpha is more. To counter that, what the companies did was they increased the central bullseye diameter, which should have been around 0.083 to 1.164. But it cannot happen according to mathematical calculations. So what did they do? They changed the primary focus of the lens onto intermediate. So what should have been 0.823 for the bullseye to have predominant distance focus, they changed the predominant focus to intermediate, and that's how they expanded the central bullseye diameter. That's what they did with the Panoptix. If you look at the central 1 millimeter scan coming in from a Panoptix, this is where the patient actually looks at distance, and you can see a very clear-cut myopic outcome on the tracy refraction, on the wavefront calculated refraction, just to show you. And vis-a-vis that, this is the refraction coming in from a geometric, the Vivinex geometric, where the central bullseye is dedicated for distance. As you can see, there is no myopic reading in the central 1 millimeter scan derived from the eye trace. The next factor of interest is step width. They act as slits, as we were discussing. They're always wider at the center, and as you go from the center to the periphery of the diffraction zone, the width of the slit comes down. Okay? Why it is narrower towards periphery is because there is a point where we need more diffraction, because they are standing at the periphery, so the light needs to bend more to come to the near and the intermediate focus. Then the step height, it determines the light bending from to form intermediate and near focus. There was an apodization concept where the step height progressively reduced as we went from near to from center to periphery. That was actually done to fight the photic phenomenon that was originating from the step heights, but it did not work very well because it also had a compromised near focus. It threw more light on the intermediate, so obviously the near zone. Then the diffraction zone, whether it's a full optic diffractive IOL or a partial optic diffractive IOL. So the mesopic and photopic preoperative pupillary size should be served. For example, if the photopic pupil is large, for example, then the diffraction zone should be large to cover the whole optic area, otherwise the near vision will not be good. So the full optic diffractive actually works well in these situations. Vis-a-vis that, if the mesopic pupil is small, then the diffraction zone should be small, because otherwise it will not. Okay. Now coming to the angle alpha. The angle alpha, many authorities would say that it doesn't affect the vision at all. So the angle alpha actually may or may not affect the visual acuity. You might still have a 6.6 N6, but it does affect the visual quality. I'll just give you an example. This is the point spread function of a patient who has been implanted with a Vivinex geometric, and the angle alpha is 0.315, which is well within the limits of the 0.7 millimeter central optic zone of the geometric. The PSF looks pretty good. And the encircled energy function of that particular patient, I have not changed the name of the patient for you to know that I'm talking about the same patient. The encircled energy function, as you can see, is also 99%. So the patient's energy function, the light energy that's passing through the whole IOL is pretty good, and it's pretty high in volume. Vis-a-vis that, there's another patient who has been implanted the same geometric IOL. The central bullseye is 0.7, so you should not have implanted this IOL with an angle alpha of 0.469. Look at the point spread function here. It's quite distorted. And similarly, this encircled energy function also suffers a loss. Only 74 to 92% of light energy is available to the patient for use. So this is about what we have achieved. Now, what is lying for us in the future is, we have known what diffraction does to the light. What we are working on now is, what are the component colors of the light spectrum and how to reduce the chromatic aberration, because that's one part which is not something that we have addressed to right now. So what we have understood from our discussion thus far is, the blue light refracts the most when it passes through the cornea, but the blue light diffracts the least. So it's kind of counterbalancing one another. So what one particular IOL, the Rayner trifocal, what they have done is, they have changed the orders of focus. We discussed about the orders of focus being 0, 1 and 2. What they have done is, they have changed the orders of focus to -1, 0 and 1. What they have done effectively by doing this is, the blue light which refracts the most and diffracts the least actually merge into one figure. So you do not have the components of the light spectrum forming different foci. By changing the order of focus, that is what they have achieved effectively. But how far clinically it is significant is something I'm still working on. I'm unable to, there's no equipment which can actually determine this. But this is a much better concept of counteracting the chromatic aberration than this so-called Ebbe number. The Ebbe number is actually, forgive me for using the word, it's actually a stupid concept. It does nothing to actually counter the chromatic aberration. But this echelon design is something that actually is coming up, and many trifocal designs in the future or in the pipeline are actually incorporating that. Thank you so much for the opportunity. This is where I would rest. Lot of work actually, so to understand
Anurag,
concept of.
But HLA design is already there in Symphony lenses.
Yeah.
Right?
So Symphony also does that, but Symphony does not have the order change to -1. What Rayner claims is by changing the order, and I was trying to understand from their patent papers, they've actually done some good work. The only thing that needs to be seen is, despite the orders being changed to -1, 0, and +1, the distant focus still stays at the 0 order focus. So that's still the brightest spot, and that's still the point where the chromatic aberrations are happening. So how far have they addressed to this is something that we still don't understand very well. But Echelate in the Symphony also is working. So that's what I'm saying. The Technis Symphony, by virtue of its Echelate design, actually serves the chromatic aberration more than the Ebbe number, which they actually speak that with more authority, with more pronouncement. But what works better
Abbe
is
number is a physical phenomenon. It's go through physics. Abbe number indicates
yes,
chromatic
but
aberration.
on the clinical side, it does not do much to negate the chromatic aberration. That's what I'm saying, particularly on the diffraction platform.
Yeah, particularly for the diffractive IOL, Abbe number is not important. Abbe number is important for the monofocal lenses. Abbe number is not important. Abbe number is not important when there is a change of normal optics. Abbe number is work in a spherical or aspheric IOL especially.
True. Agreed.
Welcome, Dr. Siddhartha Ghosh. She'll talk about the journey of it's a refractive IOL has changed its look.
Thank you, Dr. Arup Bhomik, for including me in this course. And I'm going to talk about refractive IOLs has changed their look, coming with big solution. Well, we all know that in the ever-evolving field of ophthalmology, the pursuit for visual perfection and patient satisfaction drives constant innovation. And that is how we have seen the evolution from monofocal IOLs to monofocal with EDOF properties, and then pure EDOF lenses, and then hybrid EDOF multifocal lenses, and then the trifocal lenses. So it is interesting that there has been a great evolution, and we have just heard from Dr. Arup Bhomik about the EDOF lenses. Well, what I am going to talk about, there will be some overlap although, but what I am going to talk about are the purely refractive lenses and how they are going to change the scenario in the future. This is one lens which is purely a refractive lens, and this is the light adjustable lens, and this is actually a multi-piece or a 3-piece monofocal IOL which is made of silicon and filled with macromers. These macromers are photosensitive material which can change the shape of the lens when irradiated with ultraviolet light. Well, how does it happen? It is interesting to understand that this particular lens, when it is implanted in the eye, and then whatever residual refractive error remains can be corrected within the eye. The lens is inside the eye, and you can correct the shape of the lens, wherein you can change the dioptric power of the lens. So that is really interesting. After a few days, when healing is relatively good, we do a refraction, and once the refractive gap is ascertained, you can irradiate the lens. Say this is how it is done. The UV rays are this lens is treated with UV rays. There is polymerization of the macromers, and the shape of the lens changes. Once the desired refraction is achieved, we can lock in with further irradiation of the whole lens, so that no further changes would happen, and that gives us the final result. So for hyperopic changes, you have to make, if you want to add plus power, you have to irradiate the central part with UV rays. And to change, to have myopic powers, you have to irradiate the periphery. So this is how it is being done. And interestingly, this is available as LAL light adjustable lenses, LAL and LAL plus. There are two varieties. LAL plus is EDOF lens, and all these varieties are also available as toric versions. So now, as for the indications, most patients are suitable for these lenses. But to my mind, what I feel, the patients with a previous history of refractive cataracts, refractive surgeries, wherein there is a higher risk of refractive surprises that we get from our standard biometries and formulae, those gap can be corrected with this lens. They are the most suitable patients because we can change the power of the lens after implantation. So this is one, but there are some contraindications as well. These lenses are not good for patients with nystagmus or a severe corneal scar or who had a previous history of herpes keratitis. Well, next I'll come to the IC8 from Athera. This is a small aperture lens, and as you can see, there is a dark annular ring, and this dark annular ring will block the paraxial rays, and this small aperture technology actually allows only the central light rays to focus on the retina, providing a EDOF effect. Well, this we have already heard about SIFI well ready, and this is where the spherical aberrations, the opposite spherical aberrations in each annular. There are 3 zones, and each one has an opposite spherical aberration, and that is how EDOF profile is achieved. This one we are very used to, we have been using for quite some time. This is the VVT lens and from Alcon, and what it does is it actually stretches and shifts the wavefront, and that is how EDOF profile is attained. And as you can see, there is a 1 micron elevation, there is a surface elevation, there are no rings, and there is another surface transition zone in the center. So this will stretch and shift the wave front. You will see now how it does. So the emerging rays are going like this, and from this is the stretching that starts from the elevation central elements, and it just stretches it or delays the wavefront and shifts in front, so that most of the light is being used for the EDOF effect. And of course, the Lucidis lens, this is another new type of refractive EDOF hybrid lens, where the central aspheric element is surrounded by a outer refractive ring. Well, IHANS, we all know, we have been using for quite some time. The difference in anterior surface is visually not detectable, but the center of the lens, there is increased thickness and there is an increased curvature there. And a similar technology is done on the posterior surface of PRC lens to attain the EDOF effect. I need to mention the Envista because this is an optic which is aberration free, and the basic concept here is to use the corneal aberration which provides for an added depth of focus. So these lenses are more forgiving because even slight decentration won't matter. Well, this is another newer generation refractive EDOF lens. This is from Apasami, and Suprafo WinFocus, which is a bifocal refractive lens with an EDOF profile, and it is not people dependent, because what it does is, the light rays that pass through the 0.3 micron below the edge of the central zone, it bends inwards, which eliminates light scatter, and thereby you attain a good EDOF effect. And this is the new kid on the block, the spiral optics from Renner Galaxy. We don't have all the information for this lens, but it is a full vision lens, and there is very minimal dysphotopsia. there are no diffractive spiral optics, so there is no loss of light as such, and these are also available as torics. This gives good near vision, and the best part is the surface do not have any discontinuities, no steps or any annular rings. This has a smooth optics. In want of time, this discussion can go on, but I think I'll end here. Thank you.
Thank you, Siddhartha. It's really tricky and very, very difficult to understand the optics of the all lenses. And I'll invite Dr. Sugata Pal as a last speaker of this session. Recent future of IOL design.
Thank you all for including me in this course. Good morning, everyone. So I'll be speaking on the recent future of IOL design. খুলেছি তো। You can connect the. Oh, খুলে রেখে দিই। ठीक है। So thank you. So my talk will have some overlapping slides or thing with Dr. Siddhartha's, because light adjusting lens is also a future in India. It's maybe working in USA, but still in India it's future. So we have seen from couching without glasses to cataract operation with glasses, then presbyopic lenses without glasses, and as always, our dil mange more, and we are looking for lenses which will correct everything without halos, and all the future research works are going in that direction. And to help with that, accurate biometry is required, and biometry has also progressed a lot. So as Siddhartha has talked about light adjustable lenses, I'll skip that. But main aim of this was to correct the residual astigmatism or residual spherical power due to biometry inaccuracy. And as Siddhartha has pointed out, basically they have this silicon macromer, which with lies become polymer, they attach and migrate to the treated area, and the perfusion continues. And then when you feel that the refraction of the patient is perfect, you irradiate the rest of the portion of the lens to lock in and get the perfect power. Now, this was approved by FDA in 2017, but in India is still a future. And as Dr. Ghosh has mentioned, that we cannot use this lens in macular disease or in patients who have increased sensitivity to the ultraviolet light, or patient on medication like tamoxifen, which is retinal toxic, and obviously patient with nystagmus, because treatment will be difficult, the irradiation will be difficult. Now, these are the drugs which makes us sensitive to UV light, so and probably few more will be added by the time this lens reaches India. Now, for hyperopic correction, we treat the central portion, and when the perfect power is found, there is a bulge, and we then lock in when the perfect power is achieved. Similarly, in myopia, we irradiate the peripheral portion to help the macromer formation, polymer formation in the periphery, so the lens in the middle thinned out, and then we lock in to get the perfect myopic correction. Now, as I have said, the future lenses are aiming for correction of both near, distance, intermediate without halos, and all the research works are targeted in that way. But unfortunately, as we know, the significant problem of the light-splitting presbyopic IOL is the dysphotopsia. And all dysphotopsia has lessened, as our previous speakers are saying, by the changing of the lens designs or technology, but true accommodative lenses if we get, will have no dysphotopsia and helps us to manage the presbyopia. Now, one lens came in about 25 years back, and it was the first presbyopic accommodative IOL crystal lens, but unfortunately, it depends more on sorry, not here. I'm talking about USA. It was approved 25 years back in USA in the research work. And then the problem was it mainly depending on the vertex movement of the eye, not on the lens movement. But now there are several accommodative IOL which mimics the natural accommodative process, and they provide both distance, near and intermediate vision without dysphotopsia. And I'll talk about few of those lenses. Now, the first one is the Juven, which is from LensGen. This is a modular lens. Modular, we know about our modular kitchen where all the parts come in different packs and they are just fitted in. Same is this lens. It has two portions. One portion is the side portion along with the base lens, which is basically made of fit in the capsular bag, and on the top of that base lens, this power lens is fitted. It is a fluid lens which is placed on the top of the base lens. Now, when the ciliary body contracts, this portion also contracts, and that changes the shape of this fluid lens to give us the accommodation. And that's how we get both the distance and the near vision. And when this relaxes, the ciliary body relaxes, these side things move away and the lens flattens to give our only the distance vision. Now, so in this patient, in this lens, the fluid lens or the accommodative lens is in the top, and the fixed silicon supporting lens is in the bottom. Now, the next lens, this lens has the advantage that because the bag is full, chances of PCR is very, very less. And it has been studied for 5 years. The chances of PCR is very minimal. Now, the study have shown presented in 2023 ASCRS monocally. They have attained good vision both for distance, intermediate and near, and the defocus curve 6 months time point showed about 2.5 diopter of accommodation, and binocularly it gives 3 diopter of accommodative power. The next lens is the fluid vision lens from Alcon. It's again slightly different design. It's not a modular lens, but is a single lens where the acrylic shell is filled with silicon oil. It's filled with silicon oil and gives an accommodative amplitude of about 2 diopter. What it does, as the ciliary muscle contract for near focus, the fluid in the haptics is pushed into the optic portion of the IOL. The fluid is pushed into the optic portion, and that gives a bulge to the IOL to give the necessary power. And once the ciliary muscles relaxes, the fluid goes out, the lens flattens, and we get the distance vision. And again, the Orion study, which was a prospective study with fluid vision comparing to Alcon IQ, has shown excellent distance corrected intermediate and near visual acuity, and contrast sensitivity was similar to the monofocal lens, and amplitude of accommodation was 2.20. The lens in its current form requires 3.2 millimeter of incision, and that hopefully will come down with advancement of the lens design. The next lens is the OmniView. It is again similar to the other lens, but here the fixed lens is on the top, whereas the fluid lens in the bottom. Whereas in the Juven, the fixed lens was at the bottom, and here is just the opposite. So what it does, again it is 5.6 millimeter optic, and again it's a modular lens which fits in. Now the front optic is made of hydrophobic acrylic material with 3 locking tabs. So they locks in 3 places with the bottom portion. And the shape changing fluid basically changes the power with the ciliary muscle contraction in the inner channel. So basically with same like the Alcon lens, here the fluid is pushed in, is bulged, and that basically with the fixed power lens, this gives the accommodative power of the lens. Now, again, for the OmniView, it has shown that the results are quite good. Corrected distance visual acuity is 20/20 and managed to get 20/32 across 4 diopter of defocus binocularly, and the refractive predictability was quite stable. Again, this lens require 3.5 millimeter of incision for the correction. The next lens is the Lumina lens. It is again slightly different. What it has is a hydrophilic acrylic lens. It is positioned in the ciliary sulcus, not in the bag. It is positioned in the ciliary sulcus, and it consists of 2 optical elements that each have an elastic omega shaped. You can see the omega shaped haptic, and the omega shaped haptic has a spring like function, and it has one optic has a fixed optical power of anterior element, and the anterior element provides 5 diopter, whereas the posterior element, depending upon the patient's biometry, give 10 to 25 diopter of the power. What it does in normal position, they are slided out. When accommodation is required, they slide in by the ciliary muscle contraction. Pointer ciliary muscle contraction, they slide in. They slide in to give this position to add the accommodative power, and when the accommodation is not required, they again slide out to go into this position. So the optical power here is increased with linear shift, and the helps in focusing both for distance and near. The last lens I'll be talking about, again, is slightly different design, is Opera accommodative IOL. Here, it again a modular lens, consists of 2 elements and is implanted separately. Now, this lens is implanted again in the ciliary sulcus. So, the role of the capsular bag is negated and is implanted in the ciliary sulcus. And then other thing is that the optic has rims which fits into the capsulorhexis. So the capsulorhexis has to be perfect. So here comes the role of femtosecond or zepto, because you need a perfectly sized rhexis, because the rim will fill in the rhexis margin, and this haptic will sit on the ciliary sulcus and will act again with the contraction of the ciliary muscle. It works, and again it requires 3.9 millimeter of corneal incision. So thank you. I wish we have a lens like light adjustable lens with the modular design, where we can correct this 3.9 millimeter incision SIA and also get the accommodation accordingly. Thank you so much for your hearing.
Thank you, Dr. Shogoto. It's a excellent elaborative talk regarding the future of accommodative IOL. We have a few questions we can discuss. If you have any question from the audience, you can answer this. So I have want to share 2 slides.
There's one question to Dr. Sugato. I mean, you all said these lenses, the future lenses are going to sit in the bag, in the capsular bag. So what about the bag contracture and fibrosis and pliability of the bag so that the lens changes its shape?
Yeah, not all of them. The one, the first lens, basically it fills in with the all of the bag and prevents contraction of the bag. And also it has shown in 5 years there is not much requirement of the stability, requirement of the yak capsulotomy. And the last lens, the Opera I talked about, it doesn't sit in the bag, or the previous penultimate one, they are on the sulcus. So the necessity of the bag in those lenses are not there. In fact, the Opera lens, because it's fitted on the capsule, there were high incidence of posterior capsulotomy and back contraction, and all of them had ear laser done which didn't affect the outcome of the
See,
vision.
Sugato,
because it was the
I
senior
think
research.
these dual haptics and fluid optics is lens working in the R&D almost more than 2 decades.
Yes,
Yeah.
yes,
And the dual optics, and you know that we have very positive about the Synchrony lens, which is a failed in the phase 3 trial.
Yeah.
So we are really doubtful whether lens is
Yes.
coming. And regarding the light at adjustable level, these lenses are indicated in the post refractive surgery. It was. But now the post refractive, the biometry is so good in any kind of refractive surgery. So it's a light adjustable, role of light adjustable going down. So the most cumbersome point of the light, negative point of the light adjustable lens, patient has to wear the UV protected lens
Yes.
almost 1.5 months.
Yes.
So even he cannot go out.
Yes.
So it is giving the positive trial in the Mexico and different and the 3-4 places very cumbersome. I think there is a very limited future of the LAL so far is a concern.
Yeah.
And so
See-
far anything we have Anurag has discussed.
I have a point to make. Definitely at this point, yes. Same was the situation when Harold Ridley implanted the IOL in 1949, and then it got FDA approval. The IOL FDA approval came in 1981. So 32 long years after the FDA approval came.
Actually, Harold never
1950.
applied for the FDA approved because
This- okay.
it's, you know,
But what I'm trying to
Harold
say-
Ridley was in mental trauma. He's almost in the asylum, and until unless David Apple is actually reinvented, who actually invented the IOL, and then it is came to the surface that yes, this man Harold Ridley actually invented IOL.
Yeah, but
so
what
this
I'm
is
trying to say
actually
is the progress.
yes.
What
yes.
looks impossible now, maybe in 2 years' time, treatment will come where you don't have to wear UV glasses for 4 hours, probably. not
Actually,
4
all
weeks.
American oil company make that credit that time that we are actually making the oil. They all forgot over the last 30 years. They forgot that the actual who invented the oil. So I think we have covered all the topic from history of oil. Excellent talk by Dr. Mohanto. And we have discussed how the EMV and EDOF works future and its future. And this diffractive technology which will be coming future, and what we stand by Anurag and Siddhartha and you, Dr. Sugato will discuss about the future lens and advanced technique. Thank you so much for attending this course. Yeah, thank you. We'll just take a quick go.
I'll take photo. Camera.
Hey, can you please do the background for Dr. Oil Mohanto's talk? Dr. Oil Mohanto.